So welcome all of you. Welcome to this now second session of the thorax, and we are into this Oracle exam mastery live classes over here. Okay, you can see all these features of the core features of Oracle over here, and here you can easily see that we have this live classes running. You also have the recorded classes option, notes as well as MCQs. So it's like a complete package, and we have few subscription plans right from basic plan for 3 months that start from 15K with the standard plan for 6 months that reaches up to 30K, and up till the mentorship plan that is for 12 months that is from 50K. It includes live doubt clarification and also one-to-one personalized guidance as well. Now, so therefore, urge you to book a slot for personalized counseling sessions, which are obviously much needed most, right? Okay, so let's start the session from where we left in the previous session, right? Let's start over here. So we were into this uh, azygous venous part. Okay, let me change the mode a bit over here. Okay, and I hope you guys can easily see it. All right. Okay, so we are into the azygous vein over here, and if we go from this part, then azygous vein, as we discussed, the posterior intercostal veins. The posterior intercostal veins, they drain into the whole venous system, and that is known as the azygous venous system. Okay, that is what is known as the azygous venous system. It is the complete posterior intercostal veins. So zygous means unpaired actually. Zygous system include a straight vein, okay, that lies in a paravertebral position, and you have some veins over here which are named as azygous, hemiazygous, and accessory hemiazygous veins. Okay, they are named like this manner. Function drains the blood from thoracic wall and the upper part of the lumbar region. Do remember that azygous vein is the one which is going to connect the superior and the inferior vena cava. It's going to connect the superior as well as the inferior vena cava. Okay, fair enough. Just a second. Yeah. Okay. So yeah, formed by. Now, few things over here are is you to understand that from where are they actually formed. Okay, we use this only. So this is formed from below. So there are few veins which are helping to form it. It is formed by the ascending lumbar vein and sometimes the your ascending lumbar vein and the right subcostal vein. So ascending lumbar and the right subcostal vein are the ones which are helped to form it. So you have right ascending lumbar vein and you have the right subcostal vein. Right subcostal vein. They both combine and they form the zygous vein. When it passes upward, it enters the thoracic cavity through the aortic opening. Okay, then it ascends up till the T4 vertebrae, and there see actually it is going to drain into superior vena cava. Just before that, it drains into the pericardium. Azygous vein drains into the superior vena cava. So point over here is that it is lying to the right of midline. Below what we have, below we have the IVC. Just imagine over here that in this space, understand that below we have this inferior vena cava. Above we have the superior vena cava. This is superior vena cava. Now what happens is from here the azygous vein is formed by you have the ascending lumbar veins and you have the right subcostal vein. They all form this azygous vein. Azygous vein runs posteriorly, then it will curve anteriorly and it will drain into SVC. Okay, this is IVC, this is azygous vein. Now this is to the right of midline. Similar veins, now this will drain what? Azygous vein will be draining what? It is going to drain all these right posterior intercostal veins. So from here we have the right side posterior intercostal veins. They all will drain into zygous vein. But what about the left side posterior intercostal veins? For them, what actually happens is we have one more set of veins over here. They are known as hemiazygous veins. So these veins over here, they are known as hemiazygous veins. They will help to drain the left side posterior intercostal veins. The zygous system, this whole system comprised of azygous vein and accessory hemiazygous and the hemiazygous. This whole system is known as azygous system of veins. Azygous system of veins. Do remember this. And that is found where? Posteriorly. It is in the posterior part of the thoracic cavity. This is where you are going to find it. Okay, so ascends and finally terminates into SVC. The relations might be asked sometimes. Anterior lies the esophagus. So, and posterior lies the vertebrae, and to the right you have the right lung, to the left you have the thoracic duct, all these things over here. Here you can focus on the SVC, focus on the azygous vein more posteriorly, and you can see in between this red color, that is the esophagus over here. On the left side, look at the accessory hemiazygous and the hemiazygous. Okay, they all form the azygous venous system, and all these veins over here, which are written like these veins over here, these are all posterior intercostal veins, posterior intercostal veins. Okay. Okay, this is, you have removed the lungs, the heart, everything, and only the zygous system is shown. That means it's completed. There's a diagram which you can easily make, IVC, and this is SVC. On the right side, you have zygous vein, on the left side, you have accessory hemizygous above and hemizygous vein below. And these two, see, accessory hemizygous and hemizygous, you can see over here, they are both curving from left to right side around, say, vertebrae T7 and T8. And the blood from these accessory hemizygous and hemizygous, they come into a zygous vein. Basically, they all drain finally into where? Into the azygous vein only. This thing you have to understand. These are all the tributaries of the azygous vein. Here in the tributaries, look over here, we have these two veins as well. These two veins as well. So tributaries, we have the right superior intercostal, then 5th to 11th, then right bronchial. So it is not only draining the posterior intercostal veins, you have the esophagus around it, it will drain the esophageal veins. You have the pericardium around it, pericardial veins, mediastinal veins, even the right bronchial vein drains into it. So there are a lot of veins that are draining into zygous vein. Sometimes a question has come previously that which veins do not drain into a zygous vein. We have to understand that it is the right first posterior intercostal. First is a bit higher up. So where do these drain? They drain to brachiocephalic. So right first, and right, not just right, even the left first posterior intercostal. Right and left first posterior intercostal vein, they don't drain into the azygous system entirely. Okay, they drain directly to the brachiocephalic veins. This thing we have to remember. Coming down again, the same diagram over here, just go through the labelings, take a screenshot if you want. This is a diagram which you can actually make. There's no harm in making this. Remember, as I told previously, also it's a game of labelings. So start with drawing SVCs and IVCs. Then find a way to form the right ascending lumbar vein and finally draw the azygous vein. Azygous vein, try to connect it to IVC to SVC. Then on the left side, make these two veins, accessory and hemizygous. Okay. And the top you can see, these are your brachiocephalic veins. Some of the veins are entering over here as well. As simple as this is how the azygous venous system starts. Sometimes they might ask you about the hemizygous. As we have seen, it is on the left side, lower part. So it is inferior hemizygous vein. Okay, mirror image of the lower part of azygous formed on the left side. So left azygous, left ascending lumbar vein, left subcostal vein. It courses to the left diaphragm. See, these azygous and hemizygous, both of these have to actually traverse through the diaphragm. They actually have to traverse through the diaphragm to reach where? To reach the thoracic cavity. Because both of these azygous and hemizygous, they are formed in the abdomen cavity. Now they have to reach the thoracic cavity. So they have to pierce the diaphragm. Okay, from where do they pierce? The azygous vein sometimes passes through the aortic opening. Aortic opening. If not, then they will pass through the crus of diaphragm. Crus of diaphragm, both the azygous and hemizygous. Azygous will pass through the right crus of diaphragm, and the hemizygous will pass through the left crus of diaphragm. Left crus of diaphragm. Okay. Okay. So this is hemizygous vein. As it is more on the lower aspect, its tributaries are 9th to 11th. And if you talk of the accessory hemizygous vein, that is a bit higher up. So tributaries will be 5th to 8th. Above 5th on the left side, they drain into the brachiocephalic vein. So if we see over here, as we are discussing that which veins don't drain over here, left and right, here you can also say left superior intercostal vein. Okay, left superior intercostal vein, that also drains into the brachiocephalic vein, the left side. Although the right superior intercostal vein, that will go to azygous. The right superior intercostal vein, they are formed by 2nd, 3rd, and 4th post intercostal. So these superior intercostal vein, they are formed by what? 2nd, 3rd, and 4th intercostal vein. So left side, they will go to brachiocephalic again. These are the veins which do not drain directly to azygous, which do not drain directly to azygous. Which do not drain directly to azygous. Are these few veins over here? Both the sides, you have first posterior intercostal, the supreme, and the left side, you have the superior intercostal veins. Do remember this part. Okay, it has come as a question. Hemizygous, I told you, hemizygous is the lower 9th to 11th. Accessory is from 5th to 8th. 5th to 8th. Okay, here you can see. Let me highlight what we have just saw. We just saw. This is second, third, and fourth. It is going to left superior intercostal vein, draining where into this left brachiocephalic vein. On the right side, the right superior intercostal, you can see this is going directly to the azygos, but left superior intercostal is going to the left brachiocephalic. Remember this basic difference. Okay, clinical anatomy, obviously, when there is a, see, it is connecting IVC to SVC. Basically, in IVC obstructions, they help to passage of shunting of blood or collaterals develop around the xylus. Lastly, over here, we have a what is known as a sympathetic chain over here. Okay, we have sympathetic chain over here. Sympathetic chain, as I discussed earlier on, that the sympathetic outflow is from T1 to L2. So let's quickly go through it. It's a part of autonomic system that we all know that functions in the body response to stress or danger. Okay, it see, parasympathetic and sympathetic, the basic difference is what? In sympathetic, what happens? That the ganglia over here is close to the origin. That is, you have a short preganglionic nerve and a long postganglionic nerve. So postganglionic nerve is longer in case of sympathetic. While if we talk of parasympathetic, it will have a long preganglionic, then you have a ganglia, then you have a postganglionic. So in parasympathetic, the ganglia is close to the organ. In parasympathetic, parasympathetic ganglia will be close to the organ. So in parasympathetic, the pre-nerve is longer, while in sympathetic, the ganglia is close to the origin from where it is coming. Therefore, here you also will see a series of ganglia also. It also consists of a series of ganglia known as paravertebral ganglia. Okay. It also gives rise to a number of nerves, splanchnic that is supplying the viscera mainly for the internal organs. Three main functions of your sympathetic system over here is for fight and flight that we all are aware of, fight and flight reaction. Whenever there is an emergency for the body, the heart rate increases, blood pressure increases, breathing rate increases. Second thing is it will inhibit the rest and digest function. See, rest and digest, when this word comes to your mind, it is a function mainly of parasympathetic. And sympathetic and parasympathetic, they work opposite to each other. Not opposite, but we can say that they both work to make a balance. The balance of the body is formed by both sympathetic and parasympathetic combined. So therefore, they will resist the rest and digest because now there's some emergency, you have to run. You don't have to rest. It modulates the body temperature, sweating, pupil size, obviously. Sweating why? Because sweat glands are innervated by the sympathetic. Okay, sweat glands. So sweat glands regulate the body temperature. Pupil size, if you have to look something, so we look at the mydriasis, you have to open the pupil. That is again a function of sympathetic. So these things do remember of sympathetic. Now, if you come to the anatomy part, the sympathetic chain. The sympathetic chain, you can see over here that from T1 to T5, we said that okay, T1 to what L2. This is T1 to T12, then you have L1 and L2. That is a sympathetic outflow. Listen carefully what actually happens is. From T1 to T5 is written over here, they will supply the thoracic viscera. What is written? Postganglion fibers, they supply the heart, lungs, aorta, esophagus. While if you go below T5, they will form these nerves known as greater, lesser, and least splanchnic nerves. They are formed by the sympathetic nerves below T5. So you have over here like this is T6, 7, 8, 9, they will form the greater one. 10, 11, they form the lesser. T12, they form the least splanchnic nerves. What do? They basically supply the abdominal viscera. Okay, they might even raise the pelvic areas as well. They are known as greater, lesser, least splanchnic nerves. Also, sympathetic chain, as we discussed already, sympathetic chain, thoracolumbar division, preganglion are located where in the spinal cord. Which part of the spinal cord? Lateral, intermediate lateral column of spinal cord. That is also a question itself. And sends axons to sympathetic ganglia. The white rami and nerve fibers that contain myelinated axons which transmit signal faster than unmyelinated axons. The white rami, see, there are two things over here. If you have a sympathetic ganglia like this, then there will be a preganglionic nerve and a postganglionic. Pre, as we said, is a smaller nerve, and a post is a longer nerve. This preganglionic nerve over here is myelinated, so it is known as white rami. This postganglionic nerve is actually non-myelinated. It is non-myelinated, so we call it as gray rami communicants. Do remember this part. Okay, so the mynated one is the preganglionic. Course relations, the course relations vary according to the region. Now let us see in the cervical region, the sympathetic chain is situated upon the prevertebral fascia. They might sometimes ask you, rarely, but you can write in theory. In the thoracic region, the sympathetic chain descends in front of the neck of first rib. Neck is where behind that is vertebral column. So start from there, then the head of second to 10th rib and the bodies of this. So they are passing basically in front of the ribs, posterior aspect of the ribs. It passes in front of posterior intercostal vessels. In the abdomen, it lies where in the anterior surface of the lumbar vertebrae and psoas major muscle. Psoas major muscle is a very important anatomical landmark in the posterior abdominal wall that you'll see in the abdominal part. It passes behind both these vessels. Following diagram shows the course relation. So this diagram over here might help you as you go below. But remember this table over here. This table over here is very, very important. All the sympathetic ganglia are shown. These are few sympathetic ganglia are shown. Cervico-thoracic ganglia. There is also known as stellate ganglia, the middle cervical, superior cervical, and celiac ganglia. Okay, so these are all the important ganglia, and go below you have all these we can say as a splanchnic ganglia, or you can say also them as the prevertebral ganglia. Okay, so they are mesenteric. So you can understand the name celiac, inferior superior mesenteric. What are they innervating? They should be innervating part of the abdominal gut. Okay, celiac artery member. So they are innervating all of this. And if you go over here, if you look over here, this area, this cervical area, it is supplying what? It is supplying the head and neck regions. Particularly this area, superior, middle, and cervicothoracic. Cervicothoracic will supply some heart as well. But yeah, the superior, middle, cervical, they are supplying the head and neck regions. Then cervicothoracic will supply cervical and thoracic areas. Celiac, superior mesenteric, inferior mesenteric, renal, all of them are supplying what? The abdominal organs. Location of these ganglia are shown over here. Okay. Branch of sympathetic chain. This we already have seen. It is the white rami or the gray rami. You can just go through, take a screenshot, and you can just write it. Though it is a bit detailed, no need to write all of this. But that upper part, that was more important. Okay. You can look at the image. To understand the relation between the branches and the ganglia, you can look at the image. Let us see the image. It shows the main branch of sympathetic chain and their target organs. It's a very important diagram not to draw, but to understand. Some images we will find which will help you to understand anatomy. Some images will you find so that you can practice those and make them in the exams. This one which you can for understanding. So it shows the main branch of sympathetic chain and their target organs. It also shows the ganglia that are involved in the synapses. Just look at the diagram, things will be clear. Okay. In this diagram, if I zoom it a bit over here so that you can see it better. Right. Okay, let me use a highlighter over here. Look at the cervical sympathetic ganglia, superior, middle, inferior. The outflow of the entire sympathetic system is over here. Or let me draw it with say some different, it's a yellow color. This is all preganglionic. This is T1 to L2, sometimes may reach L3, that's it. That is the entire outflow. And then you have all of this chain of ganglia over here. You see this chain of ganglia over here. See, sympathetic reaches the entire body. That also you should know. The parasympathetic reaches some few areas of the body. But sympathetic supply has to reach the entire body. Why entire? Because it controls the sweat glands, it also controls the blood pressure in the vessels. And sweat and vessels are present normally in the entire body. So though the outflow is only from this yellow area, in the yellow area, then via these ganglia, it will go to the cervical region. Then here you can see the cardiac pulmonary plexus to the thoracic region. Then all these splanchnic nerves through where to the whole abdominal viscera and all. Then you might think then, sir, how it is going to the upper and lower limb? Remember, there you have the brachial plexus and you have the lumbosacral plexus. As we have discussed, that both of these plexuses, the nerves which are forming these plexuses are mixed. They do contain sympathetic fibers as well. That is good. Okay, this is the basic understanding for our difference between the chain and the ganglia over here. Okay, this will help you in understanding it better. Okay, let us see some questions. So student is climbing the stairs. This is the stairs over here. Student is climbing the stairs at a fast pace, and as he's late for exam, and the left got out of order. His heart is beating fast against his chest wall. This is dryness. Obviously, it's a sympathetic response, right? fight and flight response. Let's see the questions. In order structure in the upper part of the intercostal part of intercostal space from above downwards, we saw mnemonic was vein artery nerve. So look for that. I guess option number A is the best option. Part of transverse thoracic or all except. Anteriorly, I said we had a sternocostalis. So this will be a part behind the subcostalis and between here intercostalis intimi. Therefore, the answer will be serratus posterior and superior. Which artery is enlarged in correct? This is not correction of aorta, it is coarctation of aorta. It is coarctation of aorta, right? Obviously, we have that azygous system. Okay, but azygous system is for the veins. Here, there's a problem in the artery. So in this coarctation of aorta, okay, the distal part of the aorta is receiving less supply. So therefore, as the distal part of the aorta is receiving less supply, the distal part of the aorta means descending thoracic aorta. It was giving which branch? Posterior intercostal artery. Now it is receiving less supply, so it need to dilate more to receive more blood from the anterior intercostal artery. So here we can answer the posterior intercostal artery. But it is starving of blood. It will open up more so that it receives blood from the anterior intercostal artery. Why? Because anterior and posterior intercostal artery, remember, they anastomose in the intercostal spaces. Okay, so therefore, the which arteries become enlarged out of all these options, it is must be posterior intercostal artery. Which posterior intercostal veins of left side drain to axillary hemizygous? If you remember, we discussed over here that in case of all of this was the azygous vein, this was accessory and hemizygous. This was axillary hemizygous, this was hemizygous, this was azygous venous system. Here we had a 5 to 8, here we have 9 to 11, remember. And this 2, 3, 4, and even 1, 2, 3, 4, they are going to left brachiocephalic vein. Remember this. So axillary hemizygous had 5 to 8. If you have a yes, there's the option over here. 5 to 8. Okay. Simple as. So do remember these basic points over here. Okay. Now let's come to the other part. That is, let's see the part of thoracic cavity. It is the cavity of thorax. We discussed about the entire thoracic wall and muscles. Now let us look at the thoracic cavity. What's happening over there? So cavity of thorax. Main content of thoracic cavity, guys, is our lungs and heart. Lungs is the major content. Then we have an area known as mediastinum that lies between the lungs. In that mediastinum, heart is the main content. Then you have aorta, you have esophagus, you have some nerves here and there. That's it. Okay. You know, thoracic cavity is the cavity of thorax. It is enclosed in this framework, which helps in both increasing and decreasing the volume of thoracic cavity. Boundaries, let us see. Boundaries, it's simple. We have seen in thoracic cage. Anterior lies the sternum, side is the ribs, behind we have the vertebrae over here. Content are lungs and air, as I told you. Major is lungs and less is heart. Lungs, obviously, you know, it's having more space over there. Okay, here you can see the thoracic cavity. Simple diagrams is to understand. Now, write a short note on the thoracic inlet or superior aperture. Let me warn you over here. When you use the term thoracic inlet or thoracic outlet, I'm not confusing you. I'm just telling you a bit more detail so that you don't get confused later on. When we look at the thoracic cavity, we look at, okay, this is the thoracic cavity. This is the, say, the upper bottom of thoracic cavity. That is the lower bottom, right? Then we call this as the thoracic inlet, fair enough. And we'll call this as the thoracic outlet, not bad. But the thing over here is, both inlet and outlet have structures going down and structures coming above. So there's nothing perfect like what is inlet, what is outlet. Just for the sake of understanding, we have regarded this upper aperture of the thorax as thoracic inlet. Though since you reach later on in your third, fourth year surgery, in surgery for clinical purposes, they regard the upper end of the thorax as the thoracic outlet. But that is different. Once you reach there, you will deal it together. But you should know that each part of inlet and outlet, they are receiving these structures and the structures are going out of it. It is not that inlet, everything will enter only, and from outlet, everything go out only. That is not the stuff over there. So the question comes about the right about thoracic inlet or superior aperture. You should know from where to where lies the superior aperture. So it is the lower part of neck. It measures around 10 centimeter in transverse diameter 5 centimeter. People can just go through it. Inlet is somewhat, remember, it is at an angle. Inlet is not transverse like this. It is at an angle. Behind posteriorly, it is higher up. Remember, posteriorly, inlet is higher up and anteriorly, it is going down like this. This is posterior, that is anterior. It is around at an angle of 45 degrees. And you have a Simpson's fascia, you'll understand, which is covering this. So when you inhale, it is not, when you inhale deeply, it is not that your lungs apex, they are coming into your neck region. No, They are just covered by this substance fascia over here. Okay, substance fascia. Okay, so this is thoracic inlet. I told you it is slanting. Now boundaries, you can say posterior, we have the T1 vertebrae. Each side you will have the first rib, and anterior you have the upper border of mandibular sternum. That is your jugular notch over here, just jugular notch. Okay, here you can see, and this is your okay, this is your what? This is your thoracic inlet. This is your thoracic inlet. So as I said, the air is coming in and also going out. Inhale, exhale. Esophagus, food is going down, fine. Aorta, blood is going down, but the blood is going above. But in veins, the blood is going down. So stitches are coming both ways. This is your thoracic inlet. This whole area over here, this whole area, this is the thoracic inlet. Bound both sides by the first rib, anteriorly by the suprasternum, behind by the T1 vertebra. This is your thoracic inlet over here. Do remember it. Okay. So do also remember rib 2. Remember rib 2 was attaching to the sternal angle, and we'll see its relevance as well. This is the sternal angle over here. Okay. What are structures passing through the thoracic inlet? You have seen already, but just for writing, you'll see a lot of other things. So to complete the answer, you'll write about tracheoesophagus, and there are a lot of arteries. You'll write about the arteries, what are the different branches of it. Then nerves, we have the vagus, phrenic, sympathetic, and first thoracic nerves. See, vagus and phrenic, why? Because vagus starting from medulla oblongata of the brain, but it will go and supply the gut as well. Phrenic, why? Because phrenic came from C3, C4, C5 in the neck, but then it goes to supply the diaphragm as well. So they will pass through the entire thoracic cavity, both of these vagus and phrenic. Okay, so you have tubes, you have arteries, you have neural structures, and the simple diagram you can make. Applied anatomy can write about a syndrome that is known as thoracic inlet syndrome. That's not less important, it's quite important. So two structures, arch over the first rib with the subclavian artery and the first thoracic nerve. So first rib, we said that over it pass the the subclavian artery. Now these structures may be pulled or compressed by cervical rib or its variation. So what actually happens is, if structures like subclavian artery or T1 nerve or say subclavian artery are compressed, what will happen is you will have decreased blood supply to the upper limb. There will be pain paresthesia to the upper limb. Plus, if you have a problem in T1 forms a major component of ulnar nerve. So you have you have loss of power and some problem in the ulnar nerve particularly. So hand problems will be there. There will be some loss of power in the hand to begin with. Because root value of ulnar nerve was basically C8T1 with a contribution from C7. So C8T1, you can understand half of Klumpke's fallacy is this. Now let's see what substance fascia. Substance fascia is present above the apex of the pleura. That is also known as suprapleural membrane. So that is also regarded as suprapleural membrane, known as substance fascia. The tough triangular membrane, its attachments are asked. Let me be very frank, its attachments are asked. Apex is attached where? To the C7 vertebrae, not T1, C7 vertebrae. Base is attached to this first strip. So it is like this first strip over here. Okay. It is attached to what? T1 vertebrae, and here you have C7 vertebrae. Okay. So its base is over here and apex goes over here. Apex goes over here. Suprapleural membrane. Inferior surface, in below you have what? Below you have the cervical pleura, and above you have the subclavian vessels going over. This is substance fascia suprapleural. Applied anatomy prevents the lung apex from injury, prevents neck swelling during respiration. As I told you, when you take a deep inspiration, your neck doesn't become like a frog's neck. Have you seen a frog and toad neck? They inhale deeply, there's swelling up over here. It doesn't happen. Okay, so prevents the neck swelling during respiration. Okay, this suprapleural membrane that they are trying to show us over here. This thing, this stuff over here. This is C7. This is suprapleural membrane over here. Okay, again, this diagram you can make is the apex of lung are the top covered by pleura, and this is your substance fascia, and you have the vessels over here. This is your substance fascia. Quite important. Discuss the outlet in brief. Outlet will be again which part? Lower part. This is the inferior part. This is the inferior part, which is open to the thoracoabdominal diaphragm. So boundaries will be different. Lower you have the xiphoid process, sides you have the costal margin, behind you the T12 vertebrae. This you can easily understand. Do remember this inlet, outlet, and external angle over here. Enumerate now. Diaphragm, major, minor opening. This is a must-know topic over here. The must-know topic is what are the structures which are related to the diaphragm. So in diaphragm, the major openings over here are these Three openings. Large openings are basically regarded as a major. And these are your three: the IVC opening, the esophageal opening, and the aortic opening. They are at the level of T8, T8, and T12. The mnemonic of it can be used as I8, 10, X at 12. Yes. I8, 8 as in eating. I8, 10 eggs. Okay, at 12. Around 12 in the afternoon, I ate 10 eggs. Okay, came from the gym, 2 hour gym, and then I ate 10 eggs just for the protein. So what is the I8? I8 is inferior. I is inferior vena cava opening at T8 level. You can check it over here. E is your esophagus over here. E is the esophagus over here at T10 level. Okay, and A is the aortic opening at T12. Simple as that. Should remember these three major openings and some other structure they are passing through it. Now there's some apart from this, there are going to be some minor openings as well. These are small openings or minor openings. Let's go through them, read it once. They are also important. So major and minor openings. Okay. Here the diagram of the diaphragm from below. Okay. Let us see the major openings, IVC openings, opening over at the central tendon, esophagus opening, and this is the aortic opening over here. Now let me add a few stuff over here. I hope it is written further on, but don't worry. I8, 10x at 12. This thing you can remember. Now, inferior vena cava questions do come that where is this opening? This IVC opening is at the central tendon of diaphragm, point number one. Second question might come, does anything else passes through the IVC? Yes, it is a right phrenic nerve that will pass along with the IVC. Next question that can come from esophagus is, it is present where? It is present in the muscular part of diaphragm. IVC opening was at the central tendon part of diaphragm. Let's see the central tendon over. The esophageal opening is at the muscular part of diaphragm. What passes along with esophagus? You have the right and left vagus nerve, right and left tenth vagus nerve. We have. Along with this, we have the esophageal branches of left gastric artery, left gastric. This is gastric vessels. Last not the least, we have the aortic opening. It is present where? The T12 level, fine, but it is present behind median arcuate ligament. It's present behind. This is median arcuate ligament over here. It is present behind the median arcuate ligament. What else can pass along with it? Along with it, azygous vein can pass. Azygous vein can pass, and thoracic duct can pass. Yes, so thoracic duct and azygous vein can pass along with the aortic opening. These things do remember. Right, or short on cervical rib. As we discussed somewhere that okay, there can be a thing known as cervical rib. The cervical rib is nothing but it's a pathology, though it is present in 0.5 to 1% of people. It present in how many people? From 0.5 to 1%. Okay. Okay. Cervical rib is an uncommon anatomical variation. It originates from where? It originates from the costal element of C7. The rib attaches to the transverse of C7. Clinical significance is it produces a scalene triangle. Now, what is a scalene triangle? The moment you will reach the look at the head and neck, you have the scalenus anterior muscle. That scalenus anterior muscle and the structures lying below and behind it, they form a small triangle. The the thing over here is that due to the presence of cervical rib, what we have seen initially was, if you recall, that we said, okay, that this was, let me show you an image, the previous image that we have seen. Let us see that directly. Yeah. Okay, over here. Okay. So you are seeing this first rib. You are seeing subclavian vessels over it. And obviously not shown over here will be the roots of brachial plexus in the upper trunk, the lower trunk of brachial plexus. They will also be there. This first rib. Now, what happens is that sometimes, due to the presence of the cervical rib, the rib will come from the C7, so rib will be attached over here. Okay. Due to this presence, all these structures which you are seeing over here, all these structures over there, they have to arch more. They have to arch above the cervical rib, not above the first rib. So normally, suppose if an artery was arching like this before in a normal person, after cervical rib, this artery has to arch like this. And therefore, you have to understand this was the first rib. Now this is first rib, this is cervical rib. Now, due to presence of this, there will be development of what? There can be development of kinking of an artery over here. There is development of kinking of an artery, and you can imagine there can be kinking, or you can say stenosis, compression of an artery, due to which there can be dilatation distally and all that stuff. Dilation. So the anatomy, normal anatomy of the vessels, they change. Even the nerves will be compressed. Right? So it is like you on a thoracic inlet syndrome. If the nerves will be compressed, arteries will be compressed, they will lead to different problems in the upper limb. That is the whole point. Just understand the relevance of cervical rib. Now, if we come back to cervical rib over here, clinical significance, compression of brachial plexus. Because if we said that we have this brachial plexus also along with the along with the subclinical vessels. The main leads to paresthesia and underwater the hand and little finger, because it is the lower trunk, the CAT1, that is basically happening. Small hand muscles, as I told already. Vesicular compression, there can be compressions of the artery, can cause problems. So it is basically the problem in the artery and the nerves. Okay, it's scalenus anterior muscle, and behind you have cervical rib. This is the area for the scalene triangle that is actually getting reduced by the presence of another structure. Here you can diagnose, okay, in an X-ray. See, cervical rib, on a practical standpoint, this question might come like this. You can identify the problem, cervical rib is there, fine, you will be given marks. On a practical standpoint, many times the cervical rib is not radio opaque. It is formed by ligaments. Now, those ligaments are not seen to an X-ray. So many times in an X-ray, cervical rib is missed. There can be seen by some ultrasound or some MRI features over there. Okay, if your patient is having the symptoms and signs like that. List of structures that can become as sometimes as a small question. Structures lying anterior to the neck of first. Remember this 3-4 structures. Just read it. They are from medial to the lateral side. They are going from medial to lateral side. Okay. So again, you can remember the vein. You have vein, artery, and nerve over there. You have sympathetic chain. Okay, chain pulling a vein. You have a mnemonic as well over here. Chain pulling a vein. Okay, so chain is the sympathetic chain. But do remember, we are going from medial to lateral, as you will always get confused. Chain pulling a vein. Vein will be the vein, artery, and the nerve over there. That's a good mnemonic that you can use. You can also make a diagram. This question might come as a 2-number question. Okay, now comes the sternal angle. What was sternal angle? If we recall, then this was the manubrium sterni. That was the body of sternum. Okay, and this over here, guys, this was our sternal angle. This was the sternal angle. I hope you remember it, right? Now, it is so important clinically that there are a lot of stuff that is happening around the sternal angle. Okay, let us see what sternal angle. Question might come of it. Also is known as angle of Lewis, horizontal between the manubrium and body frame. Transverse ridge around say 5 centimeter below notch, sometimes be around 4 centimeter as well. Anatomical events and clinical significance associated with sternal angle. Now, these are all very, very important, guys. Just read it once, you will understand the value of sternal angle. Only one till now I've told you that from there the second rib is attached, and there you can help. It can help in counting of ribs. Other things. Ascending aorta ends over here and descending aorta starts. So the arch of aorta will lie at this part. Arch of aorta starting and end. Okay, pulmonary trunk will divide at this area. Trachea will divide into 2 bronchi. It marks the junction of superior inferior mediastinum that we'll see later on. The superior vena cava pierces the fibrous pericardium at this level. So there are 7-8 stuff, important stuff that are happening at the level of sternal angle. Okay, this is the sternal angle. So just imagine. Let me try to show you guys over here. Let's see, you have the let me try to make the heart over here like this. So the ascending aorta will start, then the whole arch of aorta is behind the manubrium, and then you have this descending aorta going down. So this whole arch of aorta, that is behind the manubrium. Simultaneously, you have this trachea coming down and it bifurcates into bronchi around the sternal angle. Simultaneously, also, you have this pulmonary trunk, which is going above like this, divides into pulmonary arteries at this particular level. Just imagine this, right? Let's see more diagrams to help you understand this. Go through this image, try to understand. Here's a image over here, shown as a practical standpoint. There's a bone over here, the sternum. This is the sternal angle or angle of Lewis, what we normally call it as. Sometimes the examiner or the question or the PG exam, whichever stage you are preparing, They might ask you the sternal angle is lying at which vertebral level? At which vertebral level? So if you trace the sternal angle behind posteriorly, it will actually intersect at which vertebrae? The answer for that question will be T4, T5. T4, T5 will be the answer for that question. T4, T5 vertebral level. Do remember this too, because see, you might think there's a why would they ask something like this? They can ask something like this. The reason being that nowadays CT MRIs are so common, so therefore you should know at which level what is happening. Therefore, they might ask you this. Moving ahead, features of typical rib. This I guess we already have done about the ribs in the previous session. This image diagram you can understand. This is the posterior aspect, that is the anterior aspect. Anteriorly, as we discussed, the actual bone ends over here. Then you have this hyaline cartilage, that is the costal cartilage. Actual bone ends over here on. You have the head having two facets, neck, tubercle, angle, where fractures normally can occur. Costal groove you can see over here in the internal surface, lower border, external surface over here, right? Ribs in this. Okay, fair enough. Now let's come to another topic known as pleura. Pleura, obviously very important. Pleura is the covering of the lungs. Pleura is the covering of the lungs. We have two parts of pleura. One that is actually glued to the lung surface is known as the visceral pleura. It will have all the properties of a viscera. Like what? It will be supplied by the same nerves, supplied by the same vessels as the viscera. So suppose the bronchial, the bronchial arteries supply the lungs, the bronchial arteries supply the visceral pleura. As the lungs are supplied or innervated by the autonomic nerves will innervate the visceral pleura as well. And the outside one is known as parietal pleura. This I guess you should remember, supplied by intercostal nerves, which are somatic nerves. So therefore, these over here, they will be what? They will be pain sensitive. P for parietal, P for pain sensitive. This visceral pleura, they are pain insensitive. Then for what are they sensitive? The visceral pleura are basically sensitive to stretch, distension, all of these things. So let us read them. So lungs are closed in a serous sac called pleural cavity. It is delicate serous membrane. You have a very potential space between them, just having some pleural fluid between them. Okay, so here's a diagram that is given. This diagram over here, this imagination is important. You take a balloon and you put your fist deep to it. Slowly, what will happen is, if you look over here, that this surface of the balloon, let me use different color, red color, this surface of the balloon, okay, is in touch with the hand. Hand, imagine it to be the viscera, say the lungs over here. So now this surface of balloon, which is in touch with the hand, that actually becomes the visceral pleura, VP. And the other surface of the balloon, if I may use some different color over here, this surface is lying outside. Okay, so that is your parietal pleura. And the space, the air between them, that is the pleural space. This is the pleural space over there. So now take a look at diagram and try to understand. The balloon was one only. Are these parietal pleura and visceral pleura connected to each other? Yes, they are connected. Where are they connected? They are connected right over here, right over here. Okay, that is the area for the root of the lungs. They are both the pleura connected. This way you can understand the pleura, not just pleura, but even the peritoneum or the pericardium. Anatomy remains the same. Imagine a fist of a hand going inside a half-filled balloon. Balloon is stuck against a wall, and your fist is going into the balloon. The surface of the balloon touching your fist will be the visceral pericardium, pleura, or peritoneum. The surface of the balloon which is touching the wall will be the parietal pleura, peritoneum, or the pericardium. And the air now between these two layers of surfaces of balloon will be pleural space, pericardial, or the peritoneal space. That's the whole point over here. Okay, so now parietal pleura is located outside, as I discussed. The surface is just connected to the wall. This actually can be given different names, like what? The part which is close to the neck region, that is known as cervical pleura. The part that is in touch with the inside of ribs, that will be known as costal pleura. The part that is in connect with the, you can say, the mediastinum, the medial side, that will be known as mediastinal pleura. And the part of the parietal pleura that is facing the upper surface of diaphragm, we call it as diaphragmatic pleura. Now you might say, so there are so many different names. Names are different according to the location of the pleura. It is the same thing. The names are different only depending on the location. For example, let us see over here. Yeah, cervical pleura is written over here. Mediastinal part of pleura, diaphragmatic part, and costal part is not labeled. Yes, it is labeled over here. These are 4 parts of parietal pleura. Vessel pleura, you don't give different names to it. So each pleura has 2 layers: inner vessel pleura, outer parietal pleura, covers the outer surface of lung, outer parietal. The different parts are written over here. What does it do, right? Okay. So it lines the thoracic cavity. Just a second. Write the comparison of visceral and parietal pleura. So what is the comparison of visceral and parietal pleura? So as we already discussed, that visceral pleura, to start with over here, it is actually covering the surfaces and the fishes of lungs. So it is in connect with the lungs throughout. Okay, it is also continuous with the parietal pleura. Remember, it's a nerve supply and its blood supply. It will be the same as that of the lungs. That is the meaning of visceral pleura. Parietal pleura has 4 subdivisions. Take a screenshot of this. I would advise you guys. Costal, diaphragmatic, cervical, and mediastinal, and read the description a bit. I told you, see, the anatomy is mainly of understanding. Okay, cervical, costal means connect to the ribs, diaphragm, neck, and mediastinal. Right? There are 4 parts of it. Again, these 4 parts are written over here. So relations are not that frequently asked for the pleura. Summarize, yes. Whenever question comes from the pleura, peritoneum, or the pericardium, always try to make a table. One side write parietal, one side write visceral pleura. And have an open, clear, conceptual mind of what is you are going to. If you understand the topic, you can easily write on it. If you start to cram everything, then obviously things become not easy. Parietal pleura is the outer layer. It is thicker and more densely packed. It is sensitive to pain temperature, innervated by intercostal nerves, sometimes from framing nerves also, subdivided into 4 parts, and fused into an inseparable from the pericardium. See what happens is, outer part is the parietal pleura, right? Connected or adjacent to the lungs are the heart as well. In the heart, the outer part is pericardium. Therefore, they are fused and inseparable to the pericardium, perivertebral fascia, and also to the endothoracic fascia. When we discuss the layers of thoracic wall, we started with skin fascia, and then we came to the intercostal muscles. Then we said in endothoracic fascia, and then we said parietal pleura. You can understand the endothoracic fascia and parietal pleura, they're sort of glued to each other. Compare it with the visceral pleura, the inner layer, it's the inner layer, fine. We all know it's an inner layer. It's thinner and less vascular, not sensitive to pain, it is sensitive to stretch and all, innervated by autonomic system. Okay, extends to wherever the lungs will go, whatever fissures and all, it will go. And it's a part of epicardium. So there's a lot of differences. Now, what is pulmonary ligament? The pulmonary ligament, they can sometimes come as a short question. It is the part of parietal pleura surrounding the root of lung. Root of lung was what? Where both the parietal and visceral pleura, they meet. Wherever those bronchi and pulmonary arteries and veins were going in and out through the lung, that area is known as the root of the lung. Parietal pleura surrounding the root of lung extends downwards behind the root, and a fold. That fold is known as pulmonary ligament. That will understand by the image. Don't worry. Parietal pleura covers the structures entering the root of the lung and extends below it. It's an extension of the parietal pleura at the root of lung. So normally imagine if the root of lung is like this. Suppose the root of lung is like this. The parietal pleura will be, and parietal vessel, they are continuous like this, and there is some prolongation below. This is known as pulmonary ligament. It contains what passes through these ligaments. These structures, they pass through these ligaments. Not major those bigger structures, but yeah, the important structures. Here you can see the location of the pulmonary ligament. This is the location of pulmonary ligament. So let us see this image. There is a hilum of lung or the root of lung, pulmonary artery, veins are shown, bronchus is shown, root obviously, pulmonary artery. Now, this extension is the pulmonary ligament. What is passing through it? Some aerial tissue, lymphatic, some vessels, some bronchial vessels as well. Relations they might not ask you. Don't worry about the relations. Function of pulmonary ligament. Yeah, that's important. It forms a potential space. Suppose someone needs more pulmonary circulation due to any reason, any physiological or pathological reason, then this pulmonary ligament will provide extra space for the dilatation or expansion of pulmonary veins. Permit descent of the root of lungs, very important. During inspiration, pulmonary ligament provides space. See, lungs and heart, they are not static organs like liver and kidney. Lungs and heart both are not static. You have a respiratory rate, you have a heart rate. Therefore, they are movable organs. In normal circumstances, when I'm sitting right down talking to you guys, or someone is running around, then also these structures, the whole body is moving, and these lungs and heart, they're also moving. And at that time, they move more. They are more dynamic structures. So you need some extra potential space that is provided by this pulmonary ligament over it. Understand this basic point. Now, recesses. Recesses are what? Extra spaces. So what we discussed till now, that outside we have a parietal pleura, inside we have a visceral pleura, and between what we have a pleural sac over here. Simple as that. Sometimes pleural sac, it enlarges. That time we call it as pleural recesses. Now understand it. The pleural recesses are the potential reserve space that lies between parietal and visceral pleura. This is not visual, it is visceral. It is visceral. Okay. Sometimes the spelling mistake become funnier. Okay. It is potential. Why potential? Now when you are sitting like I'm sitting, my respiratory rate could be 15, 16, 18, 20. But when I start to jog and run, my respiratory would increase dramatically because my body needs more oxygen. At that time, these recesses will come into play. Two major recesses that you have to keep in mind are the costodiaphragmatic and costomiddle. So how to remember these complicated names? No need, guys. Try the common sense. You have learned the 4 types of parietal pleura: costal, cervical, costal, diaphragmatic, mediastinum. The recess between the costal and diaphragmatic will be known as costodiaphragmatic pleura. Okay, costodiaphragmatic pleura, and that means costal pleura and the mediastinum will be known as costomediastinum. Minor recesses are some spaces behind the esophagus, some below the heart, retroesophageal and infraheardial recesses might be there. But remember the major recesses. This is the wordings of the costomediastinal and costodiaphragmatic recess. Let me just show you an image over here. No problem. Okay, let us read it. Costodiaphragmatic recess. So costal pleura was on the side, diaphragm was below. So costodiaphragmatic recess lies inferiorly between the, that is why the name is. Vertically, it measures around 5 centimeter and extends from 8th to 10th rib. That is very, very important, guys. It extends from 8th to 10th rib in the mid-axillary line. Mid-axillary is this. So in mid-axillary, it is the lowermost part of the pleural cavity, inferiormost part. So whenever there is any fluid, it starts to accumulate in pleural cavity, pleural effusion. It will start to accumulate in the costodiaphragmatic recess. So if you look at the axilla, go down, count the ribs between 8th to 10th rib in mid-inspiratory phase. That is between inspiration and expiration. Between 8th to 10th rib, you basically have the costodiaphragmatic recess. There you can tap and take the fluid out. Understand the importance of it. Costomediastinal recess lies anteriorly behind the sternum, because mediastinum is up till here only, right? And costal cartilages, the recess is filled up by the empty margin of lungs even during quiet breathing. So this is not the most inferior part of the pleura, costomediastinum. They are saying it is normally filled up by the anterior margin of the lungs because it is sandwiched between the lungs and the heart. It is located over here. This is mediastinal pleura, there is costal pleura. So this over here is costomediastinal recess. Let me try to show you over here. Okay. Can you see this part? This is costodiaphragmatic recess. And whenever it is actually very sharp, if you look at an X-ray over here, whenever there's blunting, whenever there's blunting of the costodiaphragmatic recess, then we say, okay, it means that some fluid has started to accumulate over here. Whenever there's blunting, that if this area becomes more white, fluid is collected. And costomediastinal recess will be somewhat over here. They actually present, the heart is present over here. Behind this is the area for costomediastinal recess, and this is costodiaphragmatic recess. Understand this. Okay, nerve supply. Nerve supply you already discussed. Which nerve supply is what? You can take a screenshot of this. The parietal pleura has somatic nerves, mainly intercostal, some by phrenic nerves, and the pulmonary pleura is by autonomic nerves. Just read it. Other lines. Take a screenshot if you want. Blood supply. You already know. Outside by parietal pleura have intercostal arteries. branches of internal thoracic and this. So the same intercostal arteries, okay, intercostal arteries, they are supplying the parietal pleura. Okay, the veins will drain into azygos in the posterior part, and the anterior part of the parietal pleura will drain to internal thoracic vein. Pulmonary pleura, on the other hand, or the visceral pleura, will be supplied by the arteries that are supplying the lungs. They're basically bronchial arteries or brain to bronchial veins, simple as that. So if your concept is clear, I'm saying again, if the concept is clear, anatomy becomes very easy. So if you know that the parietal pleura will be supplied by everything that is supplying the somatic or the body bone, simple as that. You won't be required to mug up the nerve supply or the blood supply. And if you know that the visceral pleura is actually supplied by the everything that is autonomic or whatever is the supply of viscera, that is the lungs over here. Okay. So name for clinical conditions, see, these are the clinical conditions: paracentesis, thoracis. As we discussed already, it is so important. You see the needle going down, draining the pleural effusion. They told go to the TB chest ward once, you'll understand. All these conditions over here. Pleurisy, inflammation, pneumothorax, air is filling, blood, water and air is filling, empyema, this pus is filling the vapors, pleural effusion is there. They can be referred pains as well. Because the intercostal nerves, they are so much very meaning by you have T7 to T12. If you remember, T7 to T12, they were known as atypical nerves, where they were going to the abdominal wall. After they supply the intercostal space, they go to abdominal wall. So if there's problem in the abdominal wall, that can refer to pain goes to the pleura as well. Or refer pain can come to the thoracic wall as well. Okay. Site of injury or to pleura during surgical procedure, there can be some sites of injury as well, depending on the procedure. Clinical question, let us see clinical question over here, that a child about 10 years of age having a sore throat, cough and fever in the third day. The child is 10 years having sore throat, cough and fever also. So there's some infection probably. Cough is there. He developed severe cough, difficulty in breathing and high temperature. With pain in his right side of chest, right shoulder and arm. Like this looks like a typical infection of the lungs, could be some clinical pneumonia. MCQs, let us see which of the following nerves innervate the costal pleura. Costal pleura is present on the outside, so you should have intercostal nerves over there. And here we have this nerve. Okay. Phrenic nerve will supply mainly the inner part of pleura, that is the mediastinal pleura. Let us write over here. It will supply the pleura, but mediastinal pleura. Okay. Which of the following nerves innervate the mediastinal? Here we should be just discussing this, and the question popped up. Lucky we are. Phrenic nerve should supply the mediastinal part of pleura. All the following arteries supply parietal pleura except. So we know, okay, musculophrenic artery supplies parietal pleura. Yes, this supplies. Yes, this bronchial artery won't supply. It will supply the viscera and the visceral pleura. One of the following arteries supply the visceral pleura. So again, I guess the option is same. You have okay, yeah, this will be the answer, right? There was all the pleura. Now we can look at the lungs. We just introduce the lungs and then we'll continue with the later on, right? So lungs, we all know lungs, right and left lung. Just to begin with, lungs, as the question might come sometime. To begin with, we have two lungs over there, meaning the right and left. Right lung is a bit bigger, left lung is a bit shorter. One of the reason is that the heart is tilted towards the left side. As the right lung is a bit bigger, it has 3 lobes, and left lung will have 2 lobes. Sometimes a reverse can occur, but we are talking about generally what actually happens normally. Okay, the right lung has 3 lobes, the left lung has 2 lobes. Okay, apex of the lung is at the superior, where you have the neck over here. The base is at the inferior, where you have the diaphragm. 3 borders will be there, anterior, posterior, inferior, and 2 surfaces will be there. Outside surface will be known as the costal surface. The outer surface, that is known as costal surface. The inner surface over there, that will be known as the mediastinal surface. Mediastinal and costal surface. This is on both the parts of both the lungs over here. Okay, so do remember that part. Okay, apex is related superiorly. Just remember the Simpson's feature that we are discussing, right? So anterior relations of the apex of the lung will be what? In front of the apex, you have the subclavian artery, internal thoracic artery, scalenus anterior muscle. Behind you have the first rib, and just go through them once. If you know where is the location we are referring to, relations, you read it once or twice. They slowly fit into your mind. You don't have to cram them later on. Okay. Base is, you can rest in the dome of diaphragm. Right side, we have the liver below, right? and left side you have the spleen and from the stomach. The relations can be there. Anteriorly, see anterior with the heart. The anterior border is occupied by hearts. Anterior border we have the cardiac notch, and below the cardiac notch on the left side particularly we have the projection. Okay, that is not uvula, it is lingula. It is lingula like a tongue, right? Lingula. So just go through these images. You'll understand where exactly the lungs are. Causal surface, this we will discuss later on, that all these parts of the lungs over here. Don't worry. Basically, in lungs, what happens? There are 2-3 things you need to know in lungs. This swelling in beforehand. You look at the structures which are lying at the root of lung. That can be asked. And in lungs, bronchopulmonary segment. Clinically important bronchopulmonary segments. The root of lung, what structures they lie? Those bronchi, the pulmonary vessels, all those lying at the root of the lungs. Okay. So guys, that was a part of our discussion over here. I hope you guys are enjoying, and don't forget for these subscription plans. They are beautiful plans, features of it. And that's all. Thanks for watching, and don't forget to follow the social media handles over here, right from YouTube to Telegram. That's all. Bye bye. I hope you liked it, and that's all for the session. See you later. Thank you.